So welcome to all of you. We had the chance, Alessandro and myself, to be in Vancouver last 2 weeks ago for CTOS. So we have selected some highlights, not only maybe from CTOS, but the highlights of what we have learned regarding soft tissue sarcoma during this last year, during ASCO, ESMO, and CTOS. So I'm delighted to introduce Alessandro to give a lecture on surgical approach, what we have learned from during this year. So we start with a systemic treatment. I'm hoping that Alessandro can open his files. So obviously, in 1 year, it's impossible in half an hour or 40 minutes to give all information we had during these 3 important meetings. Of course, it is a selection of what I find interesting in this topic. So I have different topic. Of course, we start with the gist. I think you are all aware on these slides. Ripretinib became the 4th registered drug in advanced GIST based on this randomized trial comparing ripretinib versus placebo, having an impact for ripretinib for PFS and also overall survival. And consecutively to these results, and since ripretinib had superior in vitro activity to sunitinib against imatinib-resistant secondary KIT mutation, and considering an optimistic median PFS of 10.7 months in the early phase 1, Decifera built this randomized trial comparing in 2nd line of advanced GIST ripretinib 150 milligrams daily dose versus sunitinib 50 milligrams, the FDA approval 4 weeks on and 2 weeks off, with the assumption that the median PFS would be 9 months for ripretinib versus 6 months with the usual median PFS for sunitinib in the previous trial. Unfortunately, I think you are aware on the study, the study failed to demonstrate any superiority in favor of ripretinib comparing to sunitinib, both in KIT exon 11 GIST, but also in the overall population. There is some explanation. We have more and more data regarding this study. I would like to stress and to share this slide. There is always a problem with KIT exon 9 GIST patient. You see here the 60 patient. 60 patient means 20% of overall population, including this trial. And you see here the better results with sunitinib, with particularly active in KIT exon 9 comparing to ripretinib. Only this difference in exon 9 can be explained, at least in part, the non-superiority, of course, for the overall population. So maybe in future study we have to exclude this KIT exon 9 GIST patient. I remember you that we have observed exactly the same thing in the Novartis trial 10-15 years ago, when Novartis tried to compare nilotinib versus imatinib. We have exactly the same results. Nilotinib was less active than imatinib in front line. The other explanation are on this slide, so maybe a little complex, but it's very important to. I would like to share this slide with you. You see on the bottom of the slide the activity, the preclinical activity in cell lines, in resistant cell lines to imatinib, and you see here in exon. There is 2 categories of resistance, secondary resistance to imatinib, the exon 13 and 14 here in red, and you see here ripretinib has the same activity of sunitinib in terms of efficacy on exon 13 and 14. Ripretinib is has very high activity in exon 17 and 18 comparing to sunitinib. But when we make a mix of this population, it is in second line we have a majority. In second line we have a majority of exon 13 and 14. So it could be the explanation. In second line, ripretinib is not it's not as active as sunitinib due to the high rate of exon 13 and 14. But in later line, in fourth line, like in the Invictus trial, there is a high majority of exon 17 and 18. It is the reason why ripretinib is very active in fourth line, fifth line, and so on, and maybe less active in early line. Just a slide showing that ripretinib is better tolerated than sunitinib for all patients. Ripretinib is clearly, like imatinib compound, is very well tolerated in general. Another interesting abstract at ASCO is could we stop imatinib in very, very long responding patients, especially in patients achieving a complete remission, not only with imatinib alone, but with a combination of imatinib followed by surgical resection. It is a little phase 2 in Oslo, in Norway, but it's interesting because I'm convinced that some patients, there is a plateau here. When we stop imatinib, especially in patients having subsequently an efficacious treatment followed by a surgical resection, we can stop definitively imatinib and we can cure some patients. Of course, it's not the majority of patients, in some oligometastatic patients. So we have to maybe collect all this data at the European level. It's an important question. Can we stop definitively imatinib in advance this patient? The future is maybe on this slide. There is a communication at CTOS on early data regarding preclinical activity of a new tyrosine kinase inhibitor, IDRX42. IDRX the name is Intelligently Designed Precision Combination to Transform Cancer Care. They have this compound very active in the vast majority of secondary resistance mutations. So there is an ongoing phase 1, 2, and maybe phase 3 in the future. What about soft sarcoma? Jean-Yves presented during ESMO the update of our database of the French sarcoma group networks. You know, we have two networks, one of the review slide, systematically review from 2010 to 2021. I would like to insist that it already presents this data. When you review the specimen coming from non-sarcoma specialists, from non-sarcoma specialist pathology, there is each year more or less 40% of major discordance. Major discordance is between sarcoma versus intermediate of malignancy or versus benign. So it's a real major discordance for this non-specialist of anatomopathology. That's the most important thing is on the bottom. Here we review now systematically also the pathologists working in university centers, seeing more sarcoma than the other, and you give a look to the rate of major discordance. So it's always every year around 10%. So it is mandatory to review all the slides, all the specimen when a diagnosis of sarcoma is made in France. And the other network of the clinical part, we have now more than near 44,000 patients in this database, and we have analyzed survival of all patients included in this network from 2010 to 2020, splitting 3 different eras: 2010 to 2012, 2013 to 2015, and 2016 to 2020. And you see here in yellow, there is a significant advantage for the last era between 2016 and 2020. So it means that we have made progress also in this network, not only in referral center, but also in non-referral center, due in part to the large number, the increased number of biopsy before any discussion in multidisciplinary tumor board. And here you have the evolution between 30% of patients discussed before surgery to around 50% in the last year. So clearly the objective, the beautiful world will be discussed 100% of all patients before any surgery to discuss perioperative treatment in a good way. So see here, there is a significant advantage for the last year. Same thing for metastatic patient. You see here the last era, 2016 to 2020. The median overall survival of patients with metastatic soft tissue sarcoma have improved over the year. It is due, of course, of the approval of and the use of approval drug, but not only in France. You know, we have the chance to propose to our patients also off-label medication. So it is one of the explanations of the better overall survival in the last 3 years. What about localized soft tissue sarcoma, induction, radiation therapy of chemotherapy? I'm always fascinated by the results observed some years ago and already presented at ASCO by Alessandro. Was a combination, the concomitant administration of trabectedin plus induction radiation therapy, 3 courses of trabectedin. Day 1 administered on the day 1 of the first session of radiation therapy was the results of in myxoid liposarcoma, which is clearly the most chemosensitive and radiosensitive histological subtype. But more interestingly, and maybe you are not aware, this combination is also used not only in myxoid liposarcoma, but in other locally advanced and also metastatic or synchronous metastasis. Or we irradiated some locally advanced sarcoma, or we irradiated some oligometastatic patient with the same combination, and you see dramatic response. So it's clearly a high chemosensitive radiosensitivity trabectedin, and today is one of my favorite options. And at CTOS this year, there is an experience of Colorado. You see here 57.1% of objective response rate, local control rate of more than 90.5% in different histotype, not only myxoid, but you see UPS, the differentiated uterine, synovial-sarcoma. So today, one of my favorite approach in this locally advanced, sometimes inoperable patient, and in some selected patient with oligometastatic. So it will be maybe interesting in the future to collect the data of each country. Maybe my favorite talk there at ASCO this year is the evaluation of cDNA, the DNA circulating, tumor circulating DNA in localized patients. It is a very little study, but the concept is very interesting. So they made a cDNA samples when the tumor was present in the patient, and in 7 patients, cDNA was found to be positive, and after surgery, the cDNA became negative, and these patients have been followed not only by CT scan and whatever, but also by cDNA. And in some patients, in 2 patients, there is new re-elevation of circulating cancer DNA 3 months, at least 3 months before the visualization of this metastasis. So maybe in the future, in adjuvant situation, to try to best select the patient for an adjuvant therapy, systemic treatment, you can include this approach to follow the patient carefully by circulating cDNA. Now we move in advanced disease. In advanced disease in leiomyosarcoma, I think you're aware of these two, one retrospective study and one prospective one in leiomyosarcoma. Doxo-IFO is not the only combination in frontline in all sarcoma. In leiomyosarcoma, one of the best association is doxorubicin plus dacarbazine. It's one of my favorite association in all leiomyosarcoma, and more recently, the combination of doxorubicin plus trabectedin gives significant superiority comparing to doxorubicin, with a median PFS increased by 6 months, and translate also in overall survival by 6 months of benefit. And the future of leiomyosarcoma is maybe on the slide. It is a little phase 1/2 with a combination of doxorubicin and the new trabectedin of PharmaMar named lurbinectedin, who is also active in small cell lung cancer. And give a look to the dose of the association. Doxorubicin only 25 milligrams per meter square on day 1, plus the normal dose of lurbinectedin, 3.2 milligrams per meter square, giving some very interesting response in leiomyosarcoma and UPS, mixed fibrosarcoma. So one of the explanation is a pharmacokinetics synergic effect of lurbinectedin, giving significantly higher dose of doxorubicinol. So you double the dose of doxorubicinol when lurbinectedin is associated with doxorubicin. And on the slide, now it's blocked. This slide is not confidential, but is maybe a design can be modified during the next months. But it could be the future design of a randomized phase 2b followed by a randomized phase 3 in leiomyosarcoma, testing 2 different dosage of doxo 50 lurbi 2.2 versus doxo 25 versus lurbi plus lurbi 3.2 versus doxo 75 per milligram per meter square every 3 weeks. We pick the best of the 2 combinations during the phase 2b, and we followed, and study will be followed by a large randomized trial. It's only to share with you this new data. I cannot see my slide like that. Oh, okay. Just some other communication during CTOS in leiomyosarcoma. The unesbulin is a small molecule inhibitor, MD1 B cell specific mononemurin leukemia virus integration SIT1, synergistic with chemotherapy in the mouse model of leiomyosarcoma, and Brian Van Tine reported a combination of dacarbazine and this drug, PTC 596, in highly pretreated leiomyosarcoma with an interesting overall rate of near 90% and a disease control rate of 51%. So it was one of the rare phase 2 presented in CTOS who deserve further evaluation. I cannot second line and beyond. Disappointed results, only 1 minute on this slide. with a combination of trabectedin and olaparib. The phase 1/2b has already presented 2 years ago. It was disappointed, and the US trial tried to make exactly the same thing. With this combination, we are synergistic at the DNA level. There is some DNA breaks with trabectedin and double strand DNA breaks with a combination of PARP inhibitor and trabectedin. But in vivo, in human, the result was disappointing. So I think this combination have to be not developed. Some interesting things, a presentation on the prognostic factors associated with early versus late pulmonary metastasis. Older patients developed more late metastasis than younger. The male gender developed more late metastasis than female. Some histological subtype like clear cell sarcoma, dedifferentiated liposarcoma, and leiomyosarcoma give more late pulmonary metastasis in contrast to angiosarcoma, UPS, and osteosarcoma. A phase 2 trial of an inhibitor of MEK, there is this pathway was activated in some MPNST, neurosarcoma, and the combination of MEK inhibitor plus sirolimus, unfortunately, is not so active. What about immunotherapy? Today we really don't know. We have no real biological biomarkers, prognostic biomarkers, to find which kind of patient benefits the most or the worst of immunotherapy. Antoine Italiano published this pool analysis of 9 multicenter trials, including 349 patients. The objective response rate with the exclusion of alveolar sarcoma is only 8%. So it means no more active than trabectedin, than doxorubicin alone, gemcitabine or whatever. So clearly not a revolution. And the combination, if you use 2 different anti-PD-L1 or anti-CTLA-4, it's not the revolution. Who benefits the most? These 5 different histotypes: angiosarcoma, myxofibrosarcoma, epithelioid sarcoma, alveolar sarcoma, of course, and UPS. Patient having lymph node involvement is not so surprising to see this data. And more recently, Petit Prez have defined, I think you are aware on this data, these 5 different immune classes of sarcoma, the desert one and the hot sarcoma on the right part. The hot sarcoma are those where there is clearly an infiltration of lymphoid structure, and especially the tertiary lymphoid structure. So selecting this hot sarcoma can help to have more response. You see here on the bottom, the left part, the pembrolizumab role in selected hot soft tissue sarcoma comparing to the same regimen in non-selected soft tissue sarcoma. And a US team presented in neoadjuvant situation the association of nivolumab alone or nivolumab plus ipilimumab. We are in neoadjuvant situation before surgery, and in liposarcoma, in dedifferentiated liposarcoma, and another course in UPS with radiation therapies. The results are impressive, especially in the combination of nivolumab or nivolumab ipilimumab plus radiation therapy. You see in red here the residual tumor cells, but more importantly, they find exactly the same thing. The patient or the sarcoma patient having a tertiary lymphoid structure have a better prognostic in overall survival comparing to locally advanced liposarcoma or UPS not having this lymphoid, tertiary lymphoid structure. Maybe more interesting, and Adaptimmune, who are now in charge of the 2 trial of adoptive immunotherapy, have sent the dossier to the FDA due to the data. It's a complex design, and we have to select synovial sarcoma and myxoid round cell liposarcoma overexpressed or the protein MAGE4 or the protein NY-ESO1 in the context of human leukocyte antigen 2, and selecting it more or less 30% of all patients having these two protein. We make an apheresis, and we expanded ex vivo the lymphocyte against MAGE4. We made a cytodepletion by fludarabine and cyclophosphamide, and we reintroduce billions of cells of lymphocytes. It's like the T-card cells. We overexpress MAGE4 or NY-ESO1. It is one shot. You see here in treated patients in very interesting results in terms of tumor control rate, long responding patients, both in the MAGE4 program and also in NY-ESO1. You see here the median duration of response. There is very, very long duration. Only with one shot, some patients have tumor control more than 1 year, some of one more than 2 years after the reintroduction of this T-card cell. So the concept is very interesting. The study is very complex because we have to select. We have to select 100 patients to treat only 20, or more or less the rate. Who are the patients who benefit the most of this technique? More female than male. We don't know why. The more you express, especially in the MAGE4 study, more you express the protein, and more you benefit from this approach, and less the tumor is important, and more you benefit from this approach. What about in liposarcoma? You know, the well differentiated and dedifferentiated liposarcoma have the same molecular signature and amplification on the chromosome 12, MDM2, and CDK4. You see here, presented by Gounder in ASCO in CTOS also, that clearly liposarcoma is in all the other oncology model is the best model to see an amplification of anti-MDM2, and there is a lot of different labs who test, develop anti-MDM2. The first one is Boehringer. This compound gives interesting results. There is 9 PR reported out of 53 patients in DDIF and well differentiated liposarcoma. So it one of the major anti-MDM2 inhibitor. And only for your information, there is an ongoing trial comparing doxorubicin in frontline versus this compound, and another anti-MDM2 from Rain Therapeutics, the milademetan, give also interesting results in the previous phase 2. So there is an ongoing trial, not in frontline, but it's at least in second line, comparing trabectedin versus milademetan, and the study accrual is not yet finished. Just for information, it's not only liposarcoma overexpressed or amplified MDM2. There is also intimal sarcoma, low-grade osteosarcoma, some mix of fibrosarcoma or MPNS2, some endometrial sarcoma. So one of the objectives of some labs is also to try to build a basket protocol for sarcoma, and also for other tumor having a mutation or an amplification of the MDM2. In desmoid tumor, clearly a new pathway, and a new different drugs, gamma secretase inhibitors, inhibits the Notch pathway, where the Notch pathway involved also the beta-catenin pathway, PI3 So beta-catenin is involved, you know, in the desmoid tumor. So blocking this pathway could have an impact on desmoid tumor, and it is the case with nirogacestat. O'Sullivan has presented at ASCO the early phase 2 with really impressive results with PR and some ongoing PR in a vast majority of patients, including this trial. And Bernd Kasper at ESMO presented the large phase 3 study, his name is DEFI, comparing nirogacestat 100 milligrams 2 times per day versus a placebo, giving very impressive results. Here on the left, you have the results of nirogacestat in theoretically progressive patient at inclusion. Interesting enough, and I think you are aware of that, the surveillance of some patients give spontaneous also regression. So it is the reason why before any inclusion we have to prove that the patient are really in progression and not also in stable disease. The only problem with this drug is the ovarian dysfunction in the vast majority of women, and it is a problem for this young lady. It could be explained also the role of hormonal therapy in these desmoid tumors. If you block estrogen pathway, maybe you have also a positive impact on desmoid tumor. But it seems that this ovarian dysfunction seems reversible and not definitively for the chance of the patient. And just also to remember you that there is an old drug like Caelix, was very useful in advanced desmoid, especially in intra-abdominal desmoid tumor. Caelix remains one of my favorite options. It's an old drug. It's of course an anthracycline, but when a patient progressed under hormonal therapy, or maybe with this new agent, remember that all drugs are also active in the disease. And another company, Ayala, makes this, develop gamma secretase inhibitors that try to find in the part R the best schedule, or after that to build a randomized trial with the best regimen against placebo. So the gamma secretase inhibitor maybe in the future are the future of this drug. Some interesting data in pigmentitis, pigmentitis villonodular synovitis. I remember you, it's a locally aggressive tumor of the synovium, typically affect the single joints caused by the translocation 1-2 with the CSF1 overexpressed. And there is a lot of different macrophage infiltration of lymphocyte, monocyte inside the joint affected by this tumor. It's a book paracrine loop, and there is some already active drugs, pexidartinib, a small molecule. It's approved in US, not yet in Europe, giving impressive results. It is an anti-CSF1R. And Andrew Wagner gave an update of the role of pexidartinib in PVNS. all patients are included in the randomized trial. You see here the evolution over the time of the response rate will increase over time. So it's continuous administration of this drug, especially for locally advanced inoperable PVNS. There is some patient with very high huge mass affected the joint. So it is like not imatinib in GIST, but it is a proof of concept of this compound in PVNS. And more recently, the Decifera company developed vimseltinib, who is also an anti-CSF1 inhibitor, small molecule, giving impressive results in the previous in the phase 2. And there is an ongoing phase 3 randomized trial comparing vimseltinib versus placebo. One really few words: we have nothing in conventional chondrosarcoma who relapse after local treatment, and there is this new compound, Inhibrx 109, third generation agonist antibodies that targets human death receptor 5. So it is only to show you that there is something happened in the phase 1/2 study. So since we have nothing at all in this disease, there is an ongoing, only for information, ongoing trial comparing this compound versus placebo in conventional chondrosarcoma high grade. And some slide to finish my presentation. There is an update analysis from the role of laotrectinib, an anti-NTRK, in all different, very active in all cancer where there is a gene alteration of the NTRK 1, 2, or 3. There is interesting data regarding the role of interruption of this compound. You know, it's very expensive compound. There is some plateau. There is some patient achieving at least a complete remission with laotrectin followed by surgical approach. We can cure some patient, and patient who do not have any local treatment. There is also a plateau. Some patient relapse, and with the reintroduction of laotrectinib, all patients benefit of the reintroduction. So we are more or less in the same situation like when you stop imatinib in a context of tumor shrinkage. You can stop and reintroduce the drug with an activity. And to close my talk, I would like to share with you, there is a beautiful conference and controversy on the role of NGS at the time of diagnosis or during the sarcoma life of the patient. Do we need really NGS everywhere for every patient? So there is a pro and con communication. Clearly in the audience, the vast majority, and I'm sorry for Jean-Yves, we developed the pro, but the vast majority of specialist key opinion leaders are more in favor to not propose to all patients NGS due to a lot of reason. It's today is also expensive. There is not available today for in all country to make a diagnosis when an expert pathology give its opinion. The role of NGS modify only 4% of diagnosis. So the message is trust your pathologist. NGS cannot replace a pathologist. It was my last slide, if I remember, and I would like to thank for your attention.
Thanks so much, Axel. Probably we just move on and discuss in the end. I think there are many thoughts that we can address, but then please, Alessandro.
Thank you. So it's my pleasure to be here with you tonight, this afternoon, it's late afternoon, and discuss with you about some of the byproduct, I would say, of the meetings that we will be that are the subject of this evening webinar. Why so? Because when discussing with Axel and myself about what to say tonight, we came up with the idea of presenting, beside the studies that were presented and Axel summarizing his presentation, to present another reason to attend this meeting. So to look at the benefit, these meetings are able to provide to scientists from another angle. So and which is this angle? From the creation of working groups that these meetings have favored, basically fostered and somewhat facilitated. One of these working groups is definitely the one on retroperitoneal sarcoma. And this working group is called retroperitoneal sarcoma, transatlantic estalizing retroperitoneal sarcoma working group. And why is so important? Because in rare cancer, working groups are critical to advance knowledge when studies are also not formally there. So the aim of my presentation is to try to summarize in the next 20 minutes or so what has been taken place in the past years, thanks to the collaboration, thanks to the fact that we were able to meet together at CTOS and at ESMO, ASCO, and particularly at CTOS, and by meeting together to build a collaboration which has really made a change in the management of this disease. So retroperitoneal sarcoma is a rare disease, very rare disease. Can you, next slide? Next slide. And it was usually affected, usually characterized by a very dismal prognosis. In the past, the 10-year survival of patients affected by primary retroperitoneal sarcoma was in the 30% range. Next slide. This was predominantly so because of local recurrences. So most of these patients were known to recur locally, and the local recurrence was the leading cause of death. Next slide. Now, some 10 years ago, a debate about the approach on this disease took place. And next slide. Because two groups, one from Milan and one from Paris, published the results of a different approach to retroperitoneal sarcoma, showing that by this different approach, the local recurrent disease was halved. Next slide. So this debate, these results generated a big discussion between the two sides of the Atlantic. So this was one of the editorials that basically highlighted this debate. Next slide. And this debate culminated in the need to harmonize the surgical approach, because at the same time this debate was taking place, the first randomized study in the disease was being launched. So the concern was that by not harmonizing the surgical approach to this disease, there would have been a risk to compromise the results of the study. Next slide. So harmonizing the surgical approach to retroperitoneal sarcoma was the reason for the creation of this working group. Next slide. So this was just the start. And these were the people actually who met together in Milan in Malpensa in 2013, so some 10 years ago, almost 10 years ago, to and they sat around the table, they discussed raw data, and they ended up by finding an agreement on the surgical approach. Next slide. So this meeting was critical because it helped building trust. And this trust was built through the sharing of the data, raw data, to the possibility to discuss around the table. And what brought there together was ESMO. So we were there to update the ESMO recommendations. And we had the chance to have separate meetings focusing on retroperitoneal sarcoma. And and there we started the idea of working together more closely. In fact, and the first product of this decision were the development of clinical recommendations, which were not based on many data, were predominantly based on consensus. A consensus which was generated by discussion, and discussion was sometimes doesn't bring to a consensus, but we accommodated in the recommendation consensus and non-consensus on the different topics. So we ended up by having a consensus on primary retroperitoneal sarcoma, recurrent retroperitoneal sarcoma, metastatic sarcoma that were very well received by the community. Next slide. And next. And the two, the one on primary and recurrent retroperitoneal sarcoma have been recently updated, 2021 and 2023. Next slide. Then what we did, we basically started merging our series. So the series of these first 8 centers, and then later on, series of multiple centers and many other centers that decided to join this collaboration were put together. Next slide. And this led to conduct studies on multiple studies on primary retroperitoneal sarcoma. Next slide. The most important of which was the one published some 6 years ago about the different outcomes of retroperitoneal sarcoma patients according to the different histology types. Why this is so important? Because this led to the understanding of a major advancement in the understanding of the natural cause of the disease, which of course has clinical implications and also was the basis of the studies that were afterwards performed or are being performed. So liposarcoma is the histology types that recur the most, while leiomyosarcoma is the histology types that metastasize the most. So the outcome of this patient is not uniformly dominated by local control, by local recurrences. It is so in liposarcoma, while it is not so in all other histology types. Next slide. We then, of course, learned a lot about morbidity and mortality. Next slide. We were able to perform also other studies on other combination of type of surgery and morbidities. Next slide. We did studies on recurrent retroperitoneal sarcoma also. Next slide. The most important of which led to the development of a nomogram, basically, so to understand which patient to operate. And so, you know, one of the most important questions when you have a recurrent liposarcoma is what to do. Studies on specific histologies. Next slide. Validation of nomograms that are today being used for multiple reasons. One is certainly to inform patients, but also to decide treatments. Next slides. And also, we started projects on sharing tissue banks and doing joint projects on translational research. Next slide. So this movement that started in a room with 8 people expanded globally. Next slide. And you see now how attended at the meeting that we perform basically at CTOS and once a year. Next slide. We did meetings also during the pandemic, and they were also pretty much attended. Next slide. And now this group is made of more than 400 members from 181 sites, institutions from 51 countries and 5 continents. So it's a huge collaboration of a single, very rare disease, but these have really made a major change. Next slide. So beside doing retrospective studies and then working together on clinical recommendation, we also maintained the momentum to successfully recruit onto STRAS, which was the first randomized study in the disease. Next slide. So STRAS was a study conducted in Europe, but not only in Europe, also in North America, about the use of radiotherapy, so preoperative radiotherapy, and surgery versus surgery alone. Next slide. The study was successfully conducted, recruited 266 patients in 5 years and was recently published. The study didn't show a benefit in the overall population, but did show some benefit in the population of patients affected by liposarcoma. As we now would expect, at the time the study was designed, there was not the knowledge of the different pattern recurrence of the different histology types. The study was designed back in 2010 and started in 2011 when this knowledge was not available. We generated this knowledge by studying, by merging our series and working together. If we had to repeat the study today, we would certainly include only liposarcoma patients. But yes, so we were able to look also at the liposarcoma subgroup, even if this was not planned, and we were able to see a signal of efficacy in the liposarcoma group. Next slide. Next slide. Next slide. So thanks to the collaboration in the working group, we were also able to run a parallel study, a secondary study, even if retrospective, on the patient who didn't make it to enter the study in the centers that participated in the study. So we call this TREX study. And again, this was possible thanks to the collaboration that had been generated in the working group. Next slide. So I don't want to go too much into details about this. Next slide. But just to show you that this way of working together was critical to put together another series which was far larger than the one of the included patients in the study. So STRAS included 266 patients, while the cohort of patients that were treated at the 10 top recruiter of STRAS study, patients treated in these 10 centers in the same study period, but who did, for many reasons, for a variety of reasons, didn't make it to the study, was made of 831 patients, so 4 times more. Next slide. So we matched the patients in the so-called real-life patients. We matched the real-life patients and ended up by having a matched cohort. Next slide. And in the match cohort, we basically saw the same thing that we saw in the study. So we were able to confirm the study results in the real-life population. Next slide. And then we merged the match population with the TRAS population. So those two, the match population is basically the population of patients in the observational study that were matched on a one-to-one basis, and this merge led to a larger series of more than 460 patients, and this allowed us to dig a little bit deeper in the subgroups of liposarcoma and leiomyosarcoma and see that radiotherapy was basically effective, or the signal of efficacy of radiotherapy in retroperitoneal sarcoma was stronger, or was the strongest in the liposarcoma group when the grade was not high. So the grade of recurrence was not high. So G1-2, the deep liposarcoma, meaning well-differentiated liposarcoma, and G2, the differentiated liposarcoma, seem to derive a benefit from the administration of preoperative radiotherapy, while G3 liposarcoma, G3 the differentiated liposarcoma, which not only recur locally but also metastasize, and leiomyosarcoma, which don't recur locally but only metastasize, do not seem to derive a benefit from preop radiotherapy. Next slide. Next. So this is why today we believe that we have provided the best data possible to make recommendation to the patients. So in the variety of histologies type that the retroperitoneal sarcoma family is made of, the patient that you should consider pre-op radiotherapy for are those affected by well-differentiated liposarcoma and G2, the deep liposarcoma. You should not consider, at least with the data we have today, for G3, the deep liposarcoma, certainly not for leiomyosarcoma, and so on and so forth. Next slide. So the new ongoing trials, next slide, take into consideration the evidence that was generated in the following years after the design of this study, so the STRAS study, and also take into consideration the results of STRAS study. So we are basically looking at something to try to improve the outcome of patients with a high metastatic risk. We are trying to address, in other words, the high metastatic risk of leiomyosarcoma and G3, the deep liposarcoma. Next slide. This group of patients have a very dismal prognosis with the disease-free survival at 3 years of 36%. Next slide. And the study, which is ongoing, is called STRESS-2 and was started a couple of years ago and has now included 48 patients. And it is being opened also in US, in Japan, beside Australia, Canada, and Europe. Next slide. So these two other histology types should be considered for this study, where preoperative chemotherapy remains not a standard of care, but an open question is there to address, and the study to address it is available. Next slide. We are also activating STRESS-2 in order to be able to perform the same exercise that we did for STRESS-1. Next slide. We then built a registry, next slide, which is also very important because it includes a lot of patients. From January 2017, we have started a registry, which is now including some 3,000 patients. Next slide. The registry span basically globally. Patients are included from Europe, North America, Australia, South America, and North America, and Asia. Next slide. And you see here there are a number of sites that actually include most of the patients. Some 50% of the patients are included in some 6-7 centers, and the rest are included in minor centers. This will also allow us to understand better if there's a threshold in volume and other important topics about the disease. Next slide. Next slide. Data will be centralized in Milan very soon, and this centralization will help also running studies on the state-of-the-art. There will be a randomization platform, so we will be able to randomize patients with 2 questions that don't include the development of new drugs, but are also important in the management of the disease. I don't know, for example, follow-up or other stuff like this. Next slide. We also allowed, we foster actually, we favor the rotation of visit to each other institution. This also was part of the initiatives that help build the trust between all the different institutions all over the world. Next slide. Next slide. For example, in Milan, next slide, we had the international fellows, visitors, visiting professor, and beside being important, was also a lot of fun. Next slide. So this has an easy, the group has an easy structure. Next slide. And there are multiple committees that are chaired by these people. And I just want to close by saying that that attending meetings on ASCO, ESMO, and CTOS does not only help you being exposed to the top-notch science that is being presented, but also to the chance to collaborate with people that is there. The sarcoma community is a family. It's a family of people that like to work together. So all of you who are interested in sarcoma, please come join. And if you are by chance are interested in retroperitoneal sarcoma, this is an option to this group is an option to work together. If otherwise you're interested in other stuff, be aware that there are other groups like the desmoid working group, desmoid tumor working group that has been built some few years ago and is also meeting regularly to update recommendations. And the next meeting will be at the end of June. Or there are working groups on ultra sarcomas and so on and so forth. So I'll stop here, and then I would like to thank you for your attention.
Alessandro, absolutely fantastic. Thanks so much. Maybe at this point, we want to bring in Jean-Yves. Maybe you want to comment on what Alessandro and Alex shared with us. And of course, you were jumping in just for a few minutes, for a few seconds. And of course, you have to bring up that too. The pathology. Can you hear me? And the NGS.
Can you hear me?
Yeah. Yes.
Yeah. Okay. So thank you very much, Alessandro, Axel. I think that was a beautiful summary of these questions which were raised during the CTOS meeting. I have 2 comments. First one, which is the most important, is that the type of work which is constructed by this database and this clinical research group on specific entities is extremely important in working in rare cancers. It's the only way to progress significantly, which is by splitting the nosological entities per histologies, per molecular subtypes, and per site, because each site has a specific behavior. And the effort which is done by TARP, SWEG, under the umbrella of Alessandro is really the way to go forward. And actually, what we are seeing, and that was there were a series of meetings in the recent months, not only at CTOS, is try to work together worldwide to gather the information on rare entities and to define better what are the natural history of these entities and what are the response to treatment. We need to do that tumor per tumor and possibly tumor per tumor type. Also related to the site of the primary tumor in the case of retroperitoneal sarcoma. This is particularly important, but you could discuss also for specific locations such as heart tumor or lung tumor. So that's really the way to progress, and also brings the question of making mandatory at a more global level the treatment of patients in centers with high volume and if not with high volume, in centers with all multidisciplinary expertise to progress. This was already reported by many studies, and this is very much suggested by the work which has been conducted, which is the type of work which cannot be randomized by definition, which is descriptive, but is the best piece of evidence we can get. So that would be my comment, my first comment on Alessandro's presentation. For Axel's presentation, I would be probably simpler by saying, okay, well, you don't want to do molecular characterization, but all the studies that you presented included molecular characterization in the first place. So I agree that we don't need that for diagnosis, no question. But to progress and again, to split the disease entities according to what we need to do, that's something that we reference centers or centers with interest in these tumors must integrate for at least two reasons. We will identify thus entities that we don't know about, and second, we can best and define the natural history, and second, we can define best treatment. Nobody can treat with larotrectinib if we don't have the information on translocation, and for that you need a next generation sequencing. That's one of now many examples on which we need to work, and research requires NGS. Research is done in reference centers. Reference centers should be the place where sarcoma patients are treated. Ergo, all patients should have NGS, just for a joke.
Axel?
No, I agree. There is two different methods for the NGS. Of course, for diagnosis, we have to believe to our pathologists. If there is no more pathology, okay, NGS for diagnosis. But good pathology is very important prerequisite. Obviously, we have made a lot of progress in the biological demonstration, the biological approach of some niche. You speak about NTRK. There is other example of proof of concept where we need NGS, of course. It's remain for research purpose. I see today a lot of foreign people coming here. They want to have their NGS before starting any treatment in advanced phase, and we lose time, money. All people are totally, they want two things, PET scan and NGS, before starting anything. I think it's a mistake for a vast majority of sarcoma in advanced phase. In pre-treated patient, when conventional therapy became resistant, why not? But for research purpose only.
In this context, Alessandro, I think you really only have to be commended for this huge, well, let's say lifetime contribution that you initiate with it. Specifically for you, but for all what can we learn from the last 10 years that you summarized so nicely for, let's say, other areas in sarcoma? How can you foster the collaboration and apply, let's say, your experience to extremity sarcomas and other sarcomas?
Well, I think one of the most important advancement in localized soft tissue sarcoma extremity of the past 10 years has been the introduction of nomograms for the prediction of the risk. So I think risk prediction and something that is trying to be fine-tuned by the addition of genomic signatures. So, you know, there are genomic signatures that have been tested and developed in France, but not only there. And there are attempts to put together clinical and genomic signatures to try to fine-tune further the risk prediction, and also, I mean, tailor treatments according to the risk prediction. And this is certainly one of the most important advancement that has been taking place in the past 10 years in localized disease. So the understanding of which patient to treat and which not to treat, that has led to different changes. For example, there were centers where just to say chemotherapy was used more and now it's used less, like ours, for example, and others where it was used less and now it's used more, like Axel.
And where do you see the next level? Where do you want to bring this?
For me, there are two levels in the localized disease. So in the family of localized extremity and truncal, let's say, soft tissue sarcoma. The first is to try to understand how to basically switch to change them, to make them basically hot in terms of immunotherapy. So what to do to implement the use of immunotherapy by combining immunotherapy with other drugs. So Axel has shown some nice results of adoptive cell therapy in selected histology types, but what I believe is going to happen in the coming years will be to combine chemotherapy and immunotherapy to try, because chemotherapy can really turn a tumor hot, even if it's cold, and then the combination of immunotherapy may change the outcome. So this is the first thing, is to try to understand better this and to work better on immunity in order to try to also use immunological drugs, different type of immunological drugs, not just checkpoint inhibitors, number one. And second, I believe that what can be improved, as I said, was the prediction. So I believe that prediction of the risk and therefore stratification of patients in different studies can be further improved by the introduction of, by the addition to the clinical nomograms of genomic signatures and variables. I don't believe a lot in radiomics, honestly, so I need to say that I don't believe radiomics will add a lot, but certainly genomics will. Now there's also this pathomics, there is also pathomics. So people digitalize slides, pathological slides, and according to the different color, I mean, in radiomics is the 50 shade of gray, right? And in pathomics is the 50 shade of pink.
Very nice. Axel, what's your look into?
I wanted to say something. Janine, did you raise your hand?
I think we have to be more ambitious in localized disease in neoadjuvant situation. When you have bulky metastatic patient, I think the role of immunotherapy became complex. And in general, when we develop new agents in very heavily treated patient, where the level of lymphocyte is very low, not good condition patient, we have the possibility. Why we have never developed locally neoadjuvant approach is one of the reasons, because during year and year we see the patient after a whoop surgery, so not before any surgery. So we have time during this period when the tumor is only localized with a large, even in large volume, to try to develop new approach, new standard, to understand what's happened inside the tumor in localized disease, not only in advanced phase. We have to be more ambitious in neoadjuvant situation, You see the combination of trabectedin and radiation therapy. We discovered this combination 20 years after approval of trabectedin. Maybe too late, but we have to develop neoadjuvant approach and stop all surgeons think that all these tumors are totally chemo-resistant, radio-resistant, immunoresistant, and vast majority of surgeons operate up from this. So we have to be more ambitious in the neoadjuvant situation in general.
And Jean-Yves.
Two things. First, a comment. It's very important to work on big database to define better the prognostication of the patient. That's absolutely crucial. That's a work which should have been done for a long period of time. Now we can. Now, of course, this requires, as a next step, construction of a prospective study to test and to validate that treatment A or treatment B is superior or inferior on the basis of this biomarker that we use, which is a prognosticator. That's one comment. I have another question to Alessandro, maybe to all actually. What's your perception on the constraints of data exchanges right now in Europe and beyond on our capacity to build together database? We, in the country where I work, we understood how it worked within the country. I have the impression that in all countries it's different and sometimes very difficult. How can you, how do you see the solution for this, at least in Europe, possibly beyond? Alessandro.
It is becoming an increasingly bigger problem because of regulations, and that's a fact. On the one hand, on the other hand, I mean, building database is a lot of work. Now, people talk about big data, but it is a fact that if you don't guarantee the quality of the data that you actually enter in your database, then the results you may get out of it is really, I mean, questionable at the very best, if not garbage. So there are at least two big projects ongoing in Europe that you are aware of, Geneva, that have been put together by different epidemiologists and that actually are run within also the Eurocan, the network of the European reference networks in rare tumors, and I believe that these projects are very ambitious, and I hope they will actually be successful by testing two things basically. So the possibility to use data hosted at the different institutions without moving them. So interrogating the different databases centrally, but without moving the data in order to avoid the need for a formal data sharing agreement. And this will speed up the process very much. This is possible. So, and I actually am a big fan of this project because I know how painful it is to share data in different institutions in different countries, actually. And the other one is to use artificial intelligence to try to feed databases. That is also important because we all know very well, at least I have been doing this for 26 years, how painful it is to enter data in your database. So I don't know how much you have done it, Jenny, but I did it for 26 years. So I have a 10,000 patient database that I have actually entered patient by patient by myself, which has been a lot of work. It has generated a lot of papers, so it has generated a big reach. It has been a big reach, but I cannot do it anymore. I simply can't. And nobody, I will not ask anybody to do it because it was a nightmare for me. And I was motivated to do it, but it's been impossible to maintain it forever. So it is something that has to change. And I believe that today there are tools that can improve this.
What is the solution for that, in your opinion?
I don't. What do you do with the NESA? Because I understand that also NESA has a backlog of data that is actually Genevieve.
So sorry, I was replying to SMS. Can you say again the question?
No, I was asking. I was saying how difficult it is to feed the databases. So I hope.
Oh yeah. Well, basically, I did exactly the same. I started doing it by myself because I knew what I wanted. and now it's simply impossible. Actually, just to let you, we discussed that, Alessandro, already, but it's interesting. So a few years ago with NetSarc, where we have more than 100,000 entries, we had a very important discussion, which was we have many CRAs putting data. They are reliable. They are probably as reliable, probably better than us, actually, but that's a different question. And they told us we cannot update anymore. So you choose. We update and we do a blank year, 1 year, you will have no patients, or we continue to be exhaustive. And the decision was made collectively to continue and to be exhaustive and to find another solution to update, which we are finding now. But at a given planning point, it's impossible to fill in by yourself beyond beyond a small series.
Yeah, but I believe the solution actually there are projects to try to explore different possible solutions. Because I mean, artificial
we did the extraction of electronic patient records, which is cool, which enables you to get very important data. And actually, we publish some data on tens of thousands of patients, but you cannot get in the granularity of the disease that we are treating.
Totally.
And complex.
Also the quality of data you get from the clinical electronic records is not always perfect, because people actually who fill the electronic records are not considering or thinking that this may be used for research. So there is a level of imprecision in the clinical electronic records that people don't understand, especially people that actually work in the big data family, but that are totally different from the data you put in a CRF for a study. Certainly different. But in any case, so I believe that beside this, so if we are able to show that by using artificial intelligence and electronic records, you are able to answer most of the questions that you do with your prospectively maintained database, there's no reason to continue the prospectively maintained database the way we were used to do it in the past. And there are reasons to build this collection by using artificial intelligence. And on the other hand, if you want to be more granular, you will do different projects where you will actually end up by looking more granularly to that specific subgroup of patients that you want to see. But it's important. And by the way, databases are living things. They're not just done once forever.
We don't hear you,
Alessandro, I have a question for you. You have made an impressive work on this retroperitoneal sarcoma worldwide. There is absolutely no difference between histotype, characteristic of retroperitoneal sarcoma between Asiatic, US, African.
We didn't look at that yet, Axel. This is something that we'll be looking when we look at the data that we have in the registry.
Okay.
So it's something that we will be looking at. Difference in the populations and also different in the volume, for example. There are very many different centers that self-declare to be reference center, but with different volumes. And I know that you believe that the network volume is not all being part of a network is also important. I also believe that, but I still believe that there is a volume that
there is a minimal volume under which nobody can be good. That's clear.
I have a question for you. So you said that the aim in France is to get to a point where all incident cases are discussed in a multidisciplinary board. But do you believe that this is cost effective?
It is. Actually, we published that in region. In our region, but it was cost effective. Actually, it's the same cost doing that as compared to doing badly.
No, but Geneva, I mean, because it was a proxy for a patient of being treated but in a reference center. So in my center, okay, which is a reference center, I see 1,500 new cases per year. I don't have any chance to discuss all of them. Any chance.
Oh, okay. We are not speaking of the same thing. You may find procedures which are acceptable within your center to review cases in different formats. For instance, we have MDT for diagnosis and MDT for treatment in localized and advanced phase. But all patients are seen at once. I do not see all patients. I'm like you. And I think Axel is exactly the same. It's impossible. The volume makes it impossible. But we organize things as such as the patient is being seen in our center and presented to the MDT in the majority of cases. There are exceptions, which we all agreed on, which is a small lesion, superficial, cutaneous.
Don't think you discussed dermatofibrosarcoma protuberans, do you?
Yeah, we do.
Do you?
We do. Yes.
We don't.
We do. It takes a bit of time, but not so much time, as you perfectly know.
We certainly don't. But I mean, it's, for me, what is
sorry, the DFSP, which are shown on our center, which are a selection of DFSP, as you know, because many are seen outside. We see them afterwards.
Yeah. No, but the reason why I'm asking is because, I mean, I think it is important to build the knowledge in a multidisciplinary fashion. Yeah. Important to build sarcoma track programs, training programs for sarcoma track, for sarcoma specialists, surgeons, ortho-oncs, med-oncs, rad-oncs, pathologists, and radiologists. And this is very important. It is important that the training is multidisciplinary. And I think the way hospitals and countries are organized is different. And so the way this, at the end of the day, applies to the different hospital and setups and system is different. So, for example, in Milan, we discuss a minority of patients in the formal multidisciplinary work. Yet, we are all seeing multidisciplinary. You know,
well, I think if say again, please.
I was telling Jenny because this was a discussion we had when we discussed the accreditation criteria for Huracan. Remember?
Yeah. So if I want to sum up, I think we had two excellent talks highlighting the main contributions this year and let's say complemented by let's say a huge contribution how sarcoma care is organized for retrotubercular sarcoma. And I think the discussion ended up, let's say, looking into the future. And interestingly, at least for me, of course, we talked about, let's say, radiomics, the value of NGS, diagnostics, or immunotherapy. And we realized that there are different trends. But on the other hand, what we all agreed is predictive modeling for the future will be the key, which is based on multidisciplinary treatment. And I think that's a very good completion of the year for our sarcoma webinar. We know what to do for the next year. And in this respect, I thank you, Axel, Alessandro, for, again, these huge contributions tonight. Jean-Yves, for sharing your insights, contrasting the knowledge we learned. And with this, I think thank you very much for attendance of this year's webinar.